Hello viewers, I am Dr. Rabiul. I work as an assistant professor of pathology in a medical college hospital, and I am making this video for my students and also for you. Today's topic is Sideroblastic Anemia. In this lecture, we will learn what do we mean by sideroblasts, what are the types of sideroblasts, how can we define sideroblastic anemia, the causes of sideroblastic anemia, the lab diagnosis, and the treatment of sideroblastic anemia. Okay, a lot of topics, so let's begin. First question, what do we mean by sideroblast? Recall from my previous lectures, we know whenever we see this term blast in hematology, that is indicating immature cells that are mainly found in the bone marrow. So here the blast is actually denoting erythroblast, and the sidero in this word is indicating iron. So sideroblast is erythroblast that is containing aggregates of iron. Always remember, sideroblasts are erythroblasts containing aggregates of iron. And the irons in these erythroblasts can be demonstrated by using certain stain, and that is known as Prussian blue stain. So how can we classify sideroblasts? Are they normal or are they abnormal? Now always remember there are three types of sideroblasts: type 1, type 2 and type 3. Among them, type 1 is normal, and as we will see, type 2 and type 3 sideroblasts are abnormal. So what do we mean by type 1 sideroblast? So these are normal sideroblasts, and 30 to 50% of erythroblasts in bone marrow of normal individual will be type 1 sideroblast, and they will contain few small cytoplasmic granules, and they are in fact aggregation of ferritin. So always remember that sideroblasts are of three types. Type 1 sideroblasts are normal. 30 to 50% erythroblasts in the bone marrow are in fact type 1 sideroblast. And how can we identify them? These sideroblasts will contain few small cytoplasmic granules, and these are aggregates of ferritin. Moving on to type 2 sideroblast. As I have already mentioned, type 2 and type 3, these are abnormal sideroblasts. In type 2 sideroblast, we will see that the cytoplasmic iron-containing granules are larger and numerous. And in which conditions can we see such type 2 sideroblasts? Always remember, these types are seen in hemolytic conditions and iron overload. Now, the main focus of today's lecture is in fact type 3 sideroblasts. These are also abnormal sideroblasts, and often they are also called ringed sideroblasts, because here we will have iron containing granules that will form a partial or complete ring surrounding the nucleus of erythroblast. So always remember, type 3 sideroblasts are also known as ringed sideroblasts. And as the name implies, they are forming a ring that can be complete or partial, and it is surrounding, the ring is surrounding the nucleus of erythroblast. And always remember here, the granules are in fact non-ferritin iron granules, and those granules are deposited in the mitochondria that surrounds the nucleus of the erythroblast. That's why it is having this ring shape. Now, I have already mentioned that this is very important for today's lecture, because as we will see, sideroblastic anemia is diagnosed if type 3 sideroblasts or ringed sideroblasts are more than or equals to 15% of erythroblasts in the bone marrow. So if the bone marrow has 15% or more erythroblasts that are type 3 sideroblasts, then we will say that the patient is suffering from sideroblastic anemia. And as we will see, in sideroblastic anemia, there may be dimorphic or microcytic hypochromic anemia. In case of dimorphic anemia, we will see two morphology. One will be that of microcytic hypochromic anemia, and also we will see some normocytic normochromic red blood cells as well. And as we will see, in sideroblastic anemia, there will be ineffective erythropoiesis. So what is the pathogenesis of sideroblastic anemia? The main problem is impaired heme synthesis in the mitochondria. Now, to understand the pathogenesis of sideroblastic anemia, it is important that we talk about hemoglobin synthesis, particularly heme synthesis. Now, we know that hemoglobin is composed of heme and globin. Globin is a plasma protein, and heme is made up of a ring composed of carbon, hydrogen, and nitrogen atoms, and that ring is known as protoporphyrin 9, and ferrous ion binds with the central part of this protoporphyrin 9 ring to form heme. So simply, heme means protoporphyrin 9 plus ferrous iron. Now, heme biosynthesis occurs in the mitochondria and cytoplasm of erythroid precursors in the bone marrow. I have a separate video entirely on erythropoiesis, and you can also look into that to know more about these precursor cells. For today's lecture, remember that heme biosynthesis actually begins in the pronormoblast in the bone marrow, and as the developing or precursor red blood cells are getting more and more mature, they begin to lose ribosome and mitochondria, and in the mature erythrocyte there is no ribosome and there is no mitochondria, so mature erythrocytes can no longer make hemoglobin. So how heme is forming in the mitochondria and cytoplasm? So in this image we can see that the biosynthesis begins in the mitochondria, and here what is happening, there is condensation of glycine and succinyl coenzyme A, and they are making aminolevulinic acid, and this reaction is catalyzed by an enzyme that is called aminolevulinic synthase. This particular reaction, and especially this enzyme, is very important because this is in fact the rate limiting reaction. Okay, so here in the first reaction we can see that glycine and succinyl coenzyme A, they are getting condensed to form aminolevulinic acid, and here the enzyme responsible is aminolevulinic synthase. Then what is happening? This thing is moving into the cytoplasm, and another enzyme known as aminolevulinic acid dehydratase, that is helping the second reaction, and ultimately porphobilinogen is formed. Now, after porphobilinogen is formed, in several steps we will get ultimately coproporphyrinogen 3. From that, with the help of another enzyme that you don't have to remember, ultimately we will get protoporphyrinogen 9. This is happening in the mitochondria. So from the cytosol we are now back in the mitochondria again, and ultimately from protoporphyrinogen 9 we are getting protoporphyrin 9, and from that, with the help of ferrochelatase or ferrochelatase enzyme and with addition of ferrous iron, we are making heme. And this protoporphyrin 9 is very important for today's discussion because sideroblastic anemia will develop if there is impaired synthesis of protoporphyrin 9. What will happen when there is impaired synthesis of protoporphyrin 9? The ferrous iron will not be able to bind with its target, that is the protoporphyrin 9. So where will that excess ferrous iron go? That will become deposited in the mitochondria, and that will result in formation of ringed sideroblasts. So what are the causes of sideroblastic anemia? As we can see, it can be due to genetic cause or hereditary cause, or it can be due to certain acquired causes. Acquired causes are again subdivided into primary and secondary causes. Primary cause will include refractory anemia with ringed sideroblast. Secondary causes will include certain hematological malignancies. Particularly important is myeloproliferative disorders, acute myeloid leukemia M6 type, multiple myeloma, etc. Certain drugs can also cause this anemia. They will include isoniazid, pyrazinamide, chloramphenicol, etc. Alcoholism is a very important cause. Similarly, lead poisoning can also lead to sideroblastic anemia. How does alcohol result in sideroblastic anemia? Always remember, alcohol has a direct toxic effect on erythroid precursors, and that may lead to sideroblastic anemia. So why does lead toxicity result in sideroblastic anemia? Always remember that lead interferes with protoporphyrin synthesis at several steps. For example, it inhibits the enzyme aminolevulinic acid dehydratase that was responsible for conversion of aminolevulinic acid into porphobilinogen. Again, this is also responsible for inhibiting the enzyme ferrochelatase that is responsible for incorporation of iron into protoporphyrin 9. Now, whenever we are talking about lead poisoning, we will hear a term that is called basophilic stippling. This is a classic finding that is associated with lead toxicity or lead poisoning, and this happens because lead inhibits pyrimidine nucleotidase, that is an enzyme involved in breakdown of ribosomal RNA in the reticulocytes. So since lead is inhibiting the enzyme that used to break down ribosomal RNA, so now there is undegraded ribosomes, and those undegraded ribosomes in the reticulocyte, they aggregate and they form basophilic stipplings. So basophilic stipplings are in fact aggregates of undegraded ribosomes. And the sizes of basophilic stipplings are larger in case of lead poisoning, and often they are referred to as punctate basophilic stippling. So how can we diagnose sideroblastic anemia? Always remember, in sideroblastic anemia there will be elevated serum iron, and also there will be elevated iron in the bone marrow that we can demonstrate with the help of Prussian blue reaction. The percent saturation will also be elevated, ferritin level will be also elevated, total iron binding capacity will be reduced. The last topic that we will talk about is regarding the treatment of sideroblastic anemia. Now, blood transfusion may be required in severe cases if the patient do not respond to erythropoietin, that is a hormone that used to stimulate erythropoiesis. Normally, this hormone is released from the kidney, but in case of sideroblastic anemia, this hormone is given from exogenous source. Desferrioxamine is a chelating agent, and this can be used for preventing iron overload from transfusion. In some severe cases, bone marrow transplant may be an option. In sideroblastic anemia induced by isoniazid, pyridoxine is a good treatment option, because as a matter of fact, isoniazid inhibits pyridoxine, and pyridoxine was a cofactor in synthesis of delta amino levolinate. So when that cofactor is inhibited, there is less amount of delta amino levolinate or delta amino levolinic acid, and that results in less formation of protoporphyrin 9 as we had seen in the biosynthesis of heme. So pyridoxine is the treatment of choice in sideroblastic anemia that was induced by isoniazid. So this concludes our lecture on sideroblastic anemia. I hope this brief lecture was helpful. If you like my videos, do comment and subscribe. And until next time, take care and stay blessed. Thank you.